went for academics uh, and was really proud that last week Heart India was we got that Scopus. So great job, Alok. The topic he's allotted me is how to approach coronary artery revascularization, something we do day in, day out. I'll start with what take home messages were there in the last guidelines that came. Essentially, the theme is that you involve your patient more in the decision making. It should be based on clinical indications, so there is greater thrust to clinical, regardless of sex, race, ethnicity, and try to involve the patient. We'll come to that a little later also in the slides. Try to, this is something that's not very easy. The work culture, the work ethic in India, the fabric with which we work is so different. Even two cardiologists don't work together. To expect to have a proper sharing where you have a multidisciplinary clinical cardiologist coming in, you have a surgeon, you have a physician, and you expect that is, but then that is what something which future lies in that. You should have proper teams to tackle difficult problems. Left main is the surgeon's domain, and the surgeons are going to come. PCI is reasonable when it comes to improving survival. It's better than medical therapy. So that's one change that has come about. Mortality benefit with normal LV, triple vessel disease surgery possibly improve survival. Revascularization decisions have to be based on complexity, technical feasibility, and the heart team discussions that we have, or we should have rather. The use of radial artery as a conduit over vein graft. Again, it is not my domain. I leave the surgeons to discuss on this, but that is what the guidelines say, that they encourage the use of radial artery. And radial access. I am not a radialist. I am the older generation of femoral. I am more comfortable with femoral, but the guidelines say that radial, although that is a little, I would be very interested in knowing that once angios or procedures have been done with radial, how well does the surgeon find that as a conduit? Because so these are, I think, contradictory. This is something that is new, a short duration of dual antiplatelet therapy post PCI. Earlier, we used to stop the drug that was continued was aspirin, the drug that was stopped was clopidogrel. Now they want you to continue clopidogrel and stop aspirin at 1 to 3 months post angioplasty. This requires greater understanding and greater observation in the Indian scenario. I have personally found Indians behave very differently post angioplasty as compared to the Western population. I've been doing angioplasty for a long time now, so I can say that with personal experience that our patients behave a little differently. So when it comes to even the dual antiplatelet, we have to tailor it as per the patient's risks and benefit. Stage PCI, this is something that was intuitively that I picked up in my practice. Now the guidelines say so. If your patient is very sick, do not attempt to go for complete revascularization in the single sitting. And non-culprit artery oftentimes is dangerous and stupid to do at the time when your patient is very sick. So just attempt to do as much as is essential, as you feel is clinically guided. You have to think like a clinician that this is what is the culprit. This, if I tackle, my patient is going to stabilize. Now, the same things when we come to class-wise indications, regardless, so involvement of patient, they say, shared decision-making and informed consent. We'll come to it a little more elaborate. So informed consent and patient-centric approach is what the guidelines now tell us to follow. This is also something that is very difficult in India, because all that patient's involvement is in bargaining for prices and rather than understanding the disease. So it is not something that is very easy for you to tell your patient. If you try to explain too much, they interpret it कि you are not very confident. डॉक्टर साहब को बहुत ज़्यादा कॉन्फिडेंस नहीं लग रहा, तभी वो इतना समझा रहे हैं. So this is again something that probably will evolve over time, but they say that so the first important thing is to assess the patient's ability to understand what you're trying to explain to him. He should have that IQ to understand. Try to involve the family. Try to properly explain and respect his social understanding also. Telemedicine in India, I think most of us are at the receiving end of just calls for, bad bowel habits rather than anything. And discuss alternatives also. Shared decision making, encourage questions. You will get plenty of questions. You don't have to encourage that in India. Consent. Now this legally is very important. You should word your consent properly. You should be elaborate. Most of us use signed forms, which law does not actually hold true. You should get the patient to write in his own language with a pen and paper. So although we employ forms, but that is not the ideal thing to do. Document whatever you do. Nowadays, a lot of hospitals are doing this, that they have cameras when they are explaining to the patient, so you have some evidence that you have explained to the patient. And spend some time trying to explain. It's not easy, but spend some time trying to explain and encourage a conversation with the patient and the patient's relatives. Optimal therapy often is not a very clear-cut thing. So it is good to involve more than one person when you're trying to optimize what is best for your patient. Anatomy, procedures, pain management, cost, sedation, everything goes into deciding what would be best, what is the best method to revascularize your patient. Factors to consider when it comes to anatomy: left main disease, multivessel disease, complex anatomy. These are easier dealt with by the surgeon, but there is no rule to it. The more you do, the better you get at it, and then the comorbidities that you need to look at: diabetes, systolic dysfunction, coagulopathy, valvular heart disease, frailty, malignancy, COPD, immune suppression. All these are common things that we see every day. You will not get a clear-cut patient with just CAD. You will have associated comorbidities, so you have to tailor according to what the patient is. He is breathless because of COPD. He needs to be explained before the procedure that this is not going to go away. Patient's preferences, inability, if you have to gauge whether the patient will take DAPT, will not take dual antiplatelets, his religious beliefs. Defining lesion severity, there are plenty of score systems available. Angiographically, multivessel, left main, CTOs, trifurcation, complex bifurcations, heavy calcification. Now with intracoronary lithotripsy, even we are able to manage heavy calcification quite well. Tortuosity, that is not easy. That requires it requires dexterity. Smaller stents will go, and it's not easy to tackle heavy tortuosity, that is. And aorto-osteal disease, we can quite well manage. Thrombotic lesions are troublesome in the cath lab. This I say to all the next generation. If costs permit, again that rider of course is there in India. If cost permits, please employ FFR and IVUS in your practice. It will help you understand the lesions better. Sometimes a lot of times we underestimate lengths, a lot of times we underestimate the diameters. So if you are able to use IVUS and FFR in your practice, you will end up deciding better for your patients. In STEMI, although we don't get patients, a lot of time you will not get patients within 12 hours, but within 12 hours it is a class 1 indication. Hemodynamic instability, it improves survival irrespective of time delay. If a patient has mechanical complications, of course, so auscultate your patient and do an echo before you take him up for the to the lab. So this is something that we should try to do. CABG is the obvious indication in these patients. Failed reperfusion rescue PCI should be performed to improve clinical outcomes. If within 3 to 4 hours after STEMI, intent to perform PCI is reasonable, 12 to 24 hours also, but beyond that time frame, no. So if a patient has STEMI, emergency CABG should not be performed just because he has had a failed primary. It is then better to stabilize your patient medically before you send the patient for CABG. And non-infarct artery in STEMI, please do not touch the non-infarct artery in STEMI. It is not going to benefit your patient. It will do him more harm than good. Just do the artery that is giving him STEMI. Do not attempt to completely revascularize. Elective, urgent, emergency and salvage, we all know this. Non-ST elevation MI. STEMI, of course, we understand. In NST MI, now they say that those who are at an elevated risk of recurrent ischemic events, they are candidates for revascularization. So if they have cardiogenic shock and then you try to localize the artery and fix that up, emergency revascularization is beneficial. It's a class 1A indication, reduces risk of death. So it's not just ST elevation, non-ST elevation MI is also now it is proven that it reduces the risk of death. But again, you have to work out on which artery you think is going to help the patient. Multi-vessel PCI is not advised. Non-culprit arteries in the same setting should not be performed. You should defer and stage your procedures. Now, medical therapy, I'll leave the surgical part. Revascularization to improve symptoms. If there is refractory angina despite significant stenosis amenable to revascularization, it is recommended. But if there is angina but no anatomics or physiological criteria met, then please neither CABG nor PCI should be performed. Complex disease who require revascularization, left main, highly complex CABD, we can choose CABG over PCI. Most of us do choose CABG over PCI. Diabetes, multivessel with LAD, CABG yes. Diabetes, multivessel, amenable to PCI and a poor candidate for surgery. PCI can reduce long-term ischemic events, but try to stage your procedures because that reduces the risk to the kidneys also. Those who have had a previous CABG, a patent lima, if PCI feasible, is a very reasonable alternate. We do get now a lot of patients who are post CABG who need another procedure. Pregnant patients, spontaneous dissection, it is reasonable to perform PCI. NST elevation, if medical therapy is ineffective, PCI is advised. Older population treatment strategy has to be based on patient preferences, cognitive function and life expectancy. So use prudence, use your clinical acumen to assess whether medical therapy alone is going to be good enough for your patient, then just leave your patient on medical therapy. CKD, try to minimize the risk of contrast. We'll come to that in a small slide. Assess the risk of CIN. Adequately hydrate your patient. There is no role for pre-treatment with N-acetyl cysteine. It is not known to be beneficial. No role for prophylactic renal replacement. if your patient is slated for CABG, then please delay the stabilize your patient. Try to stage it or plan your send your patient for CABG beyond 24 to 48 hours, having assessed clearly what the how the kidney is behaving. Non-cardiac surgery, routine revascularization is not recommended for obvious reasons. You don't want to risk bleed, and you don't want to risk a stent thrombosis stopping your antiplatelets. So it's always better if a non-cardiac surgery is planned and it is a reasonable risk, then go ahead and do the non-cardiac surgery first. Dr. Ashutosh had mentioned to reduce the risk of ventricular arrhythmias. Now, in this, ironically, the very patients who have polymorphic VT, who are very sick post MI, who need a procedure, are so difficult to take on table because they are high risk. And we have a very hostile sort of attitude to doctors. So, if to take that kind of a patient requires courage and luck. I have done those cases, but it is not advisable to do them in small centers. With cardiac allografts, vasculopathy, PCI is a very reasonable option. It is a class 2A indication. General procedures, radial versus femoral. Now the thrust is to use more and more of a radial approach. Choice of stents, now almost everybody is using drug-eluted stents, so DES is a class 1 indication. Use of imaging, if we can, if costs permit, then IVUS and OCT should be utilized to optimize, especially your difficult patients. You're doing left main, you're doing bifurcations. Please try to use these imaging modalities. They greatly open your eyes. You are able to get that much better outcomes. Thrombectomy, although I have used, but guidelines say they don't benefit. Calcified lesions, now we are using a lot of lithotripsy, so it is good. Sometimes even with a non-compliant balloon, we are able to achieve a reasonable result. Vein grafts. Now this is again something that is very difficult sort of a decision. If you're doing PCI for this, they say that beyond a period, you should decrease the intensity of DAPT. Whereas as grafts age, the thrombus burden increases. So it's not something that I think that has not been addressed properly in the guidelines. Benefit of CTO is uncertain. Benefit of OPing CTO with PCI is uncertain. First, viability should be assessed. Restenosis, one can quite easily do stent in stent. Now pharmacotherapy, as I said, now they say that you stop aspirin beyond 3 months, but I prefer to continue aspirin in my patients. I'm a great believer of aspirin. Prasugrel is known to increase the risk of bleeding. Clopidogrel is relatively safe. So prasugrel is good for your young patients. It's a little risky when you're dealing with something beyond 60, 70, 65, 70. Heparin and low molecular weight heparin. Although guidelines say that one can use low molecular weight heparin in PCI, not many of operators would be comfortable if the procedure's duration is beyond 40 minutes, because you cannot assess. The ACT does not give you a very true backup, and there is no clear-cut guideline as to when to repeat the second dose. So I continue to use conventional heparin in my procedures. Bivalirudin, yes, I have used, but low molecular weight heparin is safe only when your lesion selection is very clean and you're dealing absolutely simple sort of a case. I'll leave the CABG part because CABG, of course, surgical colleagues will delve in detail. Beta blockers. Beta blockers are something that has, unfortunately, this is a cyclical phenomena. I feel when we were studying, beta blockers were they were the go-to drugs for everything, and now I think there's a lot of negative for beta blockers. So beta blockers not advised if your patient has a normal LV. In a patient with AF after CABG, yes, you should try to optimize rate with it. Uh, it is better than using amiodarone in most patients because long term monitoring with amiodarone is a little more tricky. Lifestyle changes, rehabilitation, smoking cessation, psychological interventions after revascularization. That's all. Thank you.
Uh, Thank you, Dr. Rohi. And now I will invite Dr. Sanjay Kumar. He is professor and head at Institute of Medical Sciences, BHU, and he is MCHC. Sorry, Dr. Sanjay Gupta. He is a senior cardiothoracic surgeon at Fortis Hospital, Vasant Kunj, New Delhi, for his talk on management of CAD, the surgeon's perspective. Thank you, sir.
Okay. Firstly, I would like to congratulate and thanks Dr. Alok to organize such an event so regularly and inviting me nearly every time to deliver something regarding the surgery. So my topic is treatment of coronary artery disease, surgeon's view. What we can include in it that as a surgeon, our aim is always to provide best surgical treatment to our patient as per highest evidence proved guidelines, and our aim is always to give patients better quality of life with good survival benefit. So firstly we will discuss different methods of the surgery in short and some guideline based advances in indication of surgical coronary revascularization, some landmark trials and some images of CAG for the patient where surgery is indicated. So in short, the first and the only operation for which we provide for coronary artery disease patient is CABG. Old and gold standard is the on pump CABG, and later on off pump CABG, nowadays mid cap CABG, rapidly evolving especially in India, robot assisted hybrid revascularization and hard port system. Hard port system is not a method to provide the treatment, it is a method to put the patient on cardiopulmonary bypass without opening the chest, and these all are either they help during and after the surgery or they are for the ischemic heart failure surgeries, for the ischemic heart failure such as HeartMate 3, heart transplantation, and another particular thing TMLR, which once upon a time is very much talked about and now it's obsolete. This is the classical example, median sternotomy and CABG. One end we take down the lemur from the chest and one end anesmos to the LAD distal to the grafting, and this is the saphenous gain graft, top end to the ascending aorta and lower end to the artery. This is the diagrammatic representation of heart-lung machine or cardiopulmonary bypass. We took out all the blood from SVC, IVC to a reservoir, then to a oxygenator, and oxygenated blood pumped back into the ascending aorta. We can make the heart stand still after giving cardioplegia. These are the image, lots of lines are there and blood comes in contact with these lines, induce inflammatory response which is detrimental. That why off pump surgery we are opted with the help of stabilizer. We stabilize this particular portion and do the anastomosis. What is minimally invasive surgery? There is no specific definition, but the component is preferably we do it without sternotomy and without cardiopulmonary bypass. Actually it gives less trauma to the patient and better results in best hands. The persons who are regularly doing it, they are giving better results, especially with the single graft lemur to LAD. Here we open the chest by lateral thoracotomy, 4th or 5th intercostal space, and take down the lima and anasmos to the LED. This is the small incision of minimally invasive. Different type of instruments we are used, but there are certain concerns with the mid cap. There is longer and steep learning curve, because first we should learn how to take down the lima, then to learn how to anasmos and how to do off pump anasmosis. Right sided grafts are difficult to do. For left sided grafts, technique can be learned with little difficulty, and once learned the results are very reproducible. That's why it is very much popularized in our country. Top end anasmosis, when we use the vein, it is really difficult to approach the ascending aorta. They need specialized instruments. Complete revascularization is doubtful. As far as robot assisted surgery, it is performed by instruments on robotic arms that are controlled by operator from a console situated away from the operating table. This is a console. There is no sternotomy, no cardiopulmonary bypass. Surgical dexterity enhances the computer, and computer eliminate the surgeon's tremors also. This is the operating room picture. These are the specialized instruments. Specifically, this is the stabilizer octopus, which is being used during this robot assisted surgery. This is lima picture from inside. So now we come to the hybrid procedures. Once upon a time it was very much popularized, not so much nowadays. Here cardiologist and surgeon both are involved. Cardiologist did the angioplasty to non-LED vessels, and surgeons did the minimally invasive lima to LED. This is the hybrid operating room. So now we come to my topic, CAD decision making. As for the decision making of the surgery in coronary artery disease, actually this coronary artery disease is in two parts: stable coronary artery disease and acute coronary syndrome. Acute coronary syndrome, unstable angina and anistemi and STEMI. So what we are discussing here, we will see some guidelines, some landmark trials, the concept of heart team, which is very important as mentioned by earlier speaker also, and few images for the heart team concept. This is the 2014 guidelines. This is the 2018 guidelines. 2021 guidelines already discussed in very elaborating manner by previous speaker. There is nothing much for the surgeons in 2021 guidelines. Only one thing I will mention in the later period. So there are only two changes in between 2014 and 2018 guideline. These are the indication for intervention. Left main disease, proximal LAD disease, class 1 level of evidence A, 2 or 3 vessel disease with more than 50% impaired LV function, 50% and impaired LV function less than 35%. It is class 1A, but previously it was less than 40% ejection fraction. Large area of ischemia detected by functional imaging, more than 10% LV, or abnormal invasive FFR. FFR first time included in indication 2018. Single remaining patient patent coronary artery stenosis more than 50%, class 1 indication. And as far as symptoms are concerned, hemodynamically significant stenosis in the presence of limiting angina or angina equivalent with insufficient response to medical therapy, class 1 indication. Previously, they have written here less than 50% diameter. So probably they have included FFR here. Whether we do PCI or CABG, in 2018 guidelines, if it is a proximal, non-proximal LAD, surgery is class 2B indication. Means single vessel disease or double vessel disease, it is a, if it is non-proximal LAD, it is cardiologist's game, not the surgeon's game. If we come to the left main coronary artery disease, if syntax score less than 22, both surgeons and cardiologists equally can do this type of diseases. With a moderate score 23 to 32, for surgeons it is class 1A indication, for cardiologists is 2A indication. But if the disease is very much significant, it is altogether surgeons, and PCI should be preferably avoided. Triple vessel disease without diabetes mellitus, low scoring patients, both class 1A indication for both the persons, but if syntax score is more or disease is very much, it is surgeon's ball, class 1A indication, and should not be performed PCI. Important thing is that when diabetes patient is diabetic, then even with low score multivessel disease, the PCI indication class 2B, and if it is more than 22, PCI should be avoided. So now we come, we can summarize what is new in 2018 guidelines. First thing, calculation of the syntax score. They make it class 1 indication. They also say that first stabilize the NSTS ACS patient. Use of the radial artery grafts over saphenous vein grafts in patients with high degree stenosis class 1. Either you use no touch vein technique. If you have open vein harvesting, it is class 2A. Myocardial revascularization in patient with CAD, heart failure and poor LV ejection fraction less than 35%, CABG preferred class 1, PCI as alternative to CABG class 2A. Completeness of revascularization prioritized when considering CABG versus PCI. So this thing is new. Complete revascularization is new nowadays. It is being greatly told. Another thing, PCI for multivessel disease with diabetes, even with syntax score low, less than 23, PCI was downgraded from 2A to 2B. So this is what in 2018. Later on come 2021, not much for surgical revascularization. So complete revascularization is very much emphasized here. The aim is to bypass all epicardial vessels with a diameter exceeding more than 1.5 millimeter and luminal reduction of more than 50% in at least one angiographic view. FFR guided surgical revascularization has been associated with the improved graft patency. Now we come to UA, unstable angina and STEMI. Actually it come together, because ultimately when this portion abolished, then the same indication which is for SCAD are applied here. But only invasive treatment is required if patient is stabilized. A reduction in recurrent or refractory ischemia and length of hospital stay was found with early intervention. Survival benefit of the early invasive strategy appeared more pronounced in high risk subjects, including elevated cardiac biomarker at baseline, diabetes and age 75 years. So invasive strategy, whatsoever it is better, but after stabilization. In STEMI patient, STEMI is more or less is a treatment strategy for the PCI. Cardiologist aim, we are only intervene whenever there is PCI is not possible for the infarct related artery, or when we have to perform the emergency CABG when the patient is in cardiogenic shock and coronary anatomy is not feasible for PCI, or we are doing it with mechanical complications. Some landmark trials, we all know about it. Just for a revision purpose, this is the Freedom trial which was done in diabetic patient. 2012, CABG surgery is the preferred method for revascularization for patient with diabetes and multivessel CAD. STIS trial, it was done for the patients with ischemic heart failure, and they conclude that in patients randomized to STIS, there was no statistically significant difference in all-cause mortality between medical therapy alone and medical therapy with CABG. But medical therapy with CABG reduces CV mortality and morbidity compared to the medical therapy alone. So when randomized to CABG, patients are exposed to an early risk. They say that CV mortality you can reduce, but not all cause mortality. But if we go for the surgery, this is more risky for the short time. Clinical implications, CAD should be assessed and medical therapy optimized for all patients presenting with heart failure. Decision making for CABG is complex, should be individualized and taken into account the short term risk for long term benefit. So they also recommend that the STIS extension, we should see the result of STIS extension study, what happened at the end of 10 years. So this is the STIS extension study which was published in 2019. They conclude that CABG reduces all cause cardiovascular and heart failure hospitalization in time to first event and recurrent event analysis, and because of these results they have included it is in guideline less than 35% patients, less than 35% LV section fraction, surgical intervention should be done for multivessel disease class 1A indication. In Courage trial, it was a very large trial, and now 15 years follow up is already present. During an extended follow-up of up to 15 years, we did not find a difference in survival between an initial strategy of PCI plus medical therapy and medical therapy alone in patient with stable ischemic heart disease. It doesn't say you don't go, because lots of patients from PCI group, from medical group, shift to the PCI group or surgical group. The best, most powerful trial with a good strength is the Syntax trial, 2007. It is a multicentric trial. They included nearly more than 3,000 patients and 1,800 patients randomized between CABG and PCI, and these all 1,800 patients, both surgeons and cardiologists, were agreed to perform the procedure. Remaining patients, they divided into two: CABG group where PCI could not be possible, and PCI group where CABG is not possible. So subset of patients are also there where CABG is not possible, mostly due to the comorbidity. And then they shows their results. So this is the 5-year results. As far as all cause death is concerned, p value is not significant. What does it mean? At 5 years, both are results are both are the same. But if we see the cardiac death, CABG is better. For MI at 5 years, CABG is better. For CVA, CABG is better. For CVA cardiovascular accidents, p value is 0.09. It is not less than 0.05. So the both are the same. But for all cause death, CVA, MI to 5 years, CABG is better. If we see the repeat revascularization at 5 years, still this CABG is better. If we include all of them, all MACA, then 37.3% MACA rate with PCI and 26.9% with CABG. And these two are the registry patients. This is the CABG registry. See, the Syntax score is very high, 37.8. Euro score 3.9, and complete revascularization achieved in 74.7% patients. Total MACA 23.2, all death 12.6%, and cardiac death 3.6%. Whereas in PCI registry, Syntax score is low, but Euro score is much high, and complete revascularization achieved only in 36.5% of the patient. MACA was 49.2 and all death 30. So this Syntax trial was done in left main and multi-vessel disease. Some patients are having only left main, and some patients are don't having the left main, and some patients are having the both left main and multi-vessel disease. So what does, then they come to the extended, Syntax extended 10-year results published in 2020. At 10 years, no significant difference existed in all cause death between PCI using first generation stent and CABG. However, CABG provided a significant survival benefit in patients with 3 vessel disease, but not in patients with left main coronary artery disease. If you see that with left main coronary artery disease, the mortality was 27% versus 28%. That's why for left main disease, simple left main disease, it is class 1A indication both for cardiologist as far as surgeon, PCI or CABG. Then comes Syntax 2 and Syntax 3 revolution trial. So Syntax 2 trial, these are not such a trial for CABG versus PCI. However, it brings some important key messages for intervention cardiologists, also for the surgical community. It is not very much popularized also. Syntax 3, for the namesake, here they included radiologists which did the CT-CA, coronary angiography, and CT-FFR. So what they did in Syntax 2 score, there is anatomical scoring in Syntax 1, and there is some functional scoring or physiological scoring in Syntax 2, and they combined together and then gave a decision. So this is how they calculate the 4-year mortality. These are the numbers given to different particular risk factor. They include left main, gender, COPD, peripheral vascular disease, creatinine clearance for that, and they measure the 4-year mortality and then prescribe the decision. What clinicians, what cardiologists and cardiac surgical team took it in heart team approach that if age is more than 75 years and patient can be given both the options, PCI or CABG, then PCI is preferable. If creatinine clearance less, CABG is preferable. If left LVEF is less, then CABG is preferable. With the left main stem disease, if multivessel disease, CABG is better, and if multivessel disease is not there, it is better to go for the cardiologist. So these are so long trial for stent and CABG. One single trial, 10-year outcome, ART trial for the CABG patients, 3,102 CABG patients. So they compare Lima versus Bima or Lita versus Beta, single and bilateral internal memory artery. Mortality at 10 years with the single and bilateral memory artery is almost same. P value is not significant. But death, MI, stroke at 10 years, statistically there is no difference, but numerically there is difference. So what they concluded that survival following CABG in patients similar to the trial patient is excellent, 80% at the rate of 10 years. For many patients, most late events will be in the second or third decade after CABG, whether CETA or beta. Optimal medical therapy is presumably very important, and other secondary prevention measures likely also very important. Findings in ART likely most applicable to patients with stable ischemic heart disease or non-emergent ACS with low Euro score patients. So what does it implicate in indication this study? Complete myocardial revascularization. More than 80% 3+ grafts. Arterial grafting with IMA to LAD, it is a class 1 indication. Additional arterial graft in appropriate patient, class 2A indication. Radial artery graft is better than saphenous vein graft for high grade target vessel lesions, class 1 indications. Bima in patients without high risk of external infection, class 2A. Skeletonized internal memory artery harvest for patients at high risk of external wound infection, class 1 indication. This is the optimal strategy. What they suggest that for the low Euro risk patient, whether you are going off pump or on pump, there is not much difference. Virtually on pump mortality is low. Similarly, in also moderately sick patients with Euro score 3 to 5 and high risk patient where Euro score is more than 6, off pump surgery is better with P value is 0.009. Then heart team approach. So this team comprising of clinical or non-invasive cardiologist, cardiac surgeon, intervention cardiologist, as well as anesthetist and other specialists, if deemed necessary, should provide a balanced multidisciplinary decision making process. Everybody is involved, give their own views and then convey to the patient. In syntax 3 they have added radiologist also, but in robotics and mix they add patient, patient family, referring physician, radiologist for robotics and TCAB. This is a slide, the syntax score. Every artery is individually assessed and gives some numbers. So this is a patient, see how is the coronary arteries. Even surgeons are doing these type of lesions with great difficulty because runoff is not good. Another patient, left main 100% blocked and right is nearly 50% blocked. So these patients are only subjected to the CABG because stenting is not possible. Even surgery is very difficult. In this patient, we have calculated the syntax score also, the diffuse disease, LAD, circumflex. In this view, LAD is blocked, totally blocked here, and right is also blocked. Syntax score was 45.5. This is an interesting patient. There is a left main disease, there is a LAD disease. Suppose if this LAD is normal and only left main is there, it is open for both cardiologist as well as cardiac surgeon, class 1A indication. But if it is present in both, it is a multivessel disease, it is class 1A indication for surgeons, especially if diabetic. Only for the surgeons in 2021 ACC AHA guidelines is that this particular slide, that for the normal ejection fraction patient with triple vessel disease, they downgraded the CABG to class 2B indication, and similarly PCI also. So actually this is after the ischemia trial, and ischemia trial came in 2020 amid COVID. Everybody is on internet, lots of meetings are being done, so very much studied and very much discussed trial is that. So whenever this 2021 guideline comes in the picture, lots of surgical society objected it, and this Japanese society even said that we think that this trial has no relevant impact on class on recommendation for CABG. We are disappointed that no surgical association such as AATS, STS was involved in developing this new guideline. In fact, the AATS, STS, ESATS and have already declared that they do not endorse chapter 7.1 of this new guideline. So it is very sad. So I go back to the ischemia trial. I downloaded the original slides. So what I saw that the objective of this ischemia trial was the anatomical complete revascularization and functional complete revascularization, and compare it with the invasive management. But when they studied the patients, what they find out that in conservative patient, conservative management patient and invasive group of the patient, both CABG and PCI, after 4 years, the primary endpoint was not significant. That's why they come, this guideline come like that. And in conclusion, they have written that the present results suggest that among selected patients with complete chronic coronary disease and at least moderate ischemia, the outcomes of an invasive strategy may be improved if anatomic complete revascularization is achieved. The likelihood of safely achieving anatomic complete revascularization should therefore be considered when selecting between an invasive and conservative approach in patients with chronic coronary disease. So, for my topic, I conclude that the field of coronary revascularization is complex and constantly evolving. The best revascularization strategy for an individual patient must take into account clinical presentation, comorbidities, the extent and complexity of the coronary artery disease, and data from trials reflecting contemporary practice. And nowadays, there is nothing like anything PCI versus CABG. Everything is open. Cardiologists also understand, and with the heart team approach, there is no such conflict exist. Something for the CABG, as a surgical coronary revascularization is now approaching the 60th anniversary of its widespread introduction into the clinical practice. It continues to maintain an important role in the revascularization of patients with complex coronary artery disease. Actually, CABG first time done by Koslov in 1964. We are reaching, just completing 60 years after 2 years. Thank you very much.
Thank you, sir. And we'll take up the discussion after this session. So I'll invite Dr. Ritvik sir for our next talk, transcatheter aortic valve replacement versus surgical aortic valve replacement in 2022. Dr. Ritvik is Director in Cardiothoracic and Vascular Surgery at Fortis Hospital, Delhi, and his experience is more than 22 years, and he has spent a lot of time at Max Super Specialty Hospital, Parpaganj as HOD and Director. And his specialties are minimally invasive cardiac surgeries, aortic surgeries including aneurysms, total arterial CABG, mixed CABG, left ventricular assist devices, and ECMO. Over to Dr. Ritvik sir.
Thank you. Thank you so much, Dr. Alok and all the other esteemed delegates. I really enjoying these sessions now because I think it is modern session. I think it is modern debates, but I think I don't see any specific debate because we are all clear what are the guidelines say and what we are going to do. So thank you very much for giving me this topic called SAVR versus TAVR. So although it is given to me, and I come from a place, Fortis Escorts in Delhi, which is the most, who practices TAVR most widely and also practices SAVR most widely. So with this introduction, I would like to greet you from our hospital, Escort Heart in Okhla in New Delhi. That is the epitome of cardiac surgery in North India. So just for the introduction for everyone in this hall, TAVR means transfemoral aortic valve replacement, where you can replace the aortic valve either from the femoral artery or through different accesses like carotid artery, transaortic or transapical, and so on and so forth. And in surgical aortic valve is very commonly done. It's called SAVR. It's called surgical aortic valve replacement, where by open heart surgery we replace the diseased aortic valve. Both procedures are used to treat severe aortic stenosis in question on this particular topic, and I have got no financial disclosures. So, in etiology, mostly I am now talking only about aortic stenosis, because till now both the treatments, especially the TAVR group, mainly treats aortic stenosis. There are a lot of other things which you can discuss later on, but as of now 90% of TAVR is done for aortic stenosis. So mechanism is this: mainly they have some solid calcium deposits within the valve clasps. It is also a similar risk factors for coronary artery disease, and there is a high incidence of CAD and aortic stenosis in the same individual, and usually happens in 6, 7, 8 decades of our life. So if you see the disease etiology, this is the first, the bar on this side is aortic stenosis, which is mainly degenerative. Which is the blue bar is the degenerative, and the others are very small in number. In our country also, this study have shown that in Indian population, the senile valvular degeneration is the commonest cause of acquired isolated aortic stenosis, with majority of them presenting before the 60 years of age. There is a slight age difference in our country as compared to our Western counterparts. So this is the slide which has recently shown the death of patients in aortic stenosis in our country, which has been slowly increasing. And it is a very important slide to understand that most of the aortic stenosis, they start at the age of 60, and if you see the patients over the age of 65, 2% prevalence. If it goes to 75, it is 3%, and if it is 85, it is 4%. Like in 4 of 100 will be affected by aortic stenosis. Over 100,000 people in the United States are diagnosed with severe aortic stenosis every year. Prevalence of aortic stenosis and comorbidities that increase the risk of surgical valve replacement increase also with the age. Now this is also a very important slide. We must understand, as we have a lot of physicians in this forum, please do not treat them for a long time. Do not keep them giving medical treatment for a long time, because these three symptoms, the angina, syncope and heart failure, if they start appearing, especially the heart failure part, they are like the last stage of cancer. They have a very steep downhill course in their natural history. So as my previous speaker has said, CABG, similarly in aortic valve also, it was done very early in our history. In 1913, Tafier has done the first aortic valvotomy, and then there are a lot of valves came in between. I was just trying to show this valve. It's called the Starr-Edwards ball and cage valve, which has lasted almost for 6 decades in the history of cardiac surgery and in general in cardiac science. So these two gentlemen, Albert Starr and Edwards, they have Starr is a physician and Edwards is an engineer. So they have together made this valve. It's a ball and cage valve, and if you see that, I have been blessed. Dr. Sanjay must also be been blessed to put couple of these valves when it was declared and defunctioned in 2005. Till 2005 it was there. Then we have the biological valves, where Dr. Alain Carpentier in France, he developed, and there are a lot of biological valves which were there, but in 1960 onwards we have the biological valves which started for a long time lasting. This is because Dr. Carpentier, this is a French surgeon, he has a lot of history to cardiac surgery. After doing 15 or 20 years of cardiac surgery practice, he has taken sabbatical of 2 years to study only chemistry in the University of France, to discover glutaraldehyde and its impact on the storage of the biological valves, because of which we still have the good biological valves. In the TAVR valves also, the biological leaflets which we make and place in the TAVR valves, they are also equally treated with glutaraldehyde. So this is a big contribution to cardiac surgery and cardiac science in general. So then we have got a lot of these valves which are seen in different forms, in different structures, but they are mainly made of bovine pericardial tissues, which the TAVR valve is also made of. And we also have a different arm of valves called the porcine valves, which are slowly, gradually getting its popularity going down and down. Now from TAVR side, we have got Dr. Alain Kreiber. He is also from France. So he has got 3 landmark things which he has done. In 1985, he has done the first balloon aortic valvotomy. In 1995, he has done the first PTMC, and in 2002, he has done the first successful TAVR. So, this essentially about last week I have met this gentleman in our hospital. He came for some course, but great man and have great contributions to the aortic stenosis and valvular heart disease in general. So we did the first transaortic valve replacement in country in 2012. So the India in general have started the journey of TAVR in 2012. We also there's an off-level thing that also there is a accidental TAVR valve which was done way back in 2004 when a surgeon from France came to Escorts, and he had to put this valve because the surgeon was denying surgery. It is off-legal, but if you see the history of TAVR in India, it's way back in 2003, 2004. Officially, we have done in 2012, and then the TAVR have started growing rapidly and exponentially all across the globe. Was initially used to treat very high-risk cases requiring aortic valve replacements, then have some excellent short-term outcomes in these cases, and then slowly they have started deliver to the intermediate risks, and of late they have been now started to be using in the low risk groups also. Now these are different types of TAVR valves. On this side is a balloon expandable valve, and this is a self-expandable valve. So I am not going in detail because I am not supposed to talk on these things, but these are the gamut of valves which have been now in the market. So this is the Medtronic's valve, this is the Edward Life Sciences valve, and then we must know now, before going to discuss whether we should do SAVR and what should do TAVR, we should know which patients are required to go for TAVR and which patients are required to go for SAVR. So for that, in 2014, AH and ACC, they have defined these classifications: low operative risk, intermediate operative risk, high operative risk, and prohibitively high operative risk. So there are a lot of guidelines, but by and large, if you see this STS score of less than 4, 4 to 5, 8, more than 8, and if it is more than 50% chance of death at 1 year, it is very prohibitively high risk. These are trials I am not going to discuss in detail, but these are very important trials to guide us, to show us the future. So the landmark trial was the partner trial. The partner 1 started in 2010, partner 2 in 2016, and partner 3 in 2019, and the report came in 2021. And there is one more trial which is for 5 years, that is 2021 SARTAVI trial. All these trials are randomized controlled trials, and they are all multicentric. So I am not going to discuss about the partner 1 and partner 2 trial because they are a little bit old, and they are already very well defined and well structured. What partner 3 trial is more important is that this previous partner trials have shown that TAVR was superior to standard therapy in extremely risk patients and non-inferior to surgery in high-end and intermediate risk patients with aortic stenosis. So the purpose of the partner 3 was to report the clinical and echocardiographic outcomes of the partner 3 trial at 2 years for low-risk patients with severe symptomatic AS treated with SAPIEN 3 TAVR system versus surgery. So these are the inclusion and exclusion criteria. Mostly exclusion criteria, if you see, this important is bicuspid aortic valve, severe aortic rigors, severe LV dysfunction, severe calcification of the aortic valvular complex, vascular anatomy is not suitable for safe femoral access, complex coronary artery disease, left main syntax score mode of 32, or not ambience for PCI. And clinically, if the patient is having acute MI within last 1 month, stroke or TIA within last 90 days, eGFR of less than 30, hemodynamic or respiratory instability, and extremely frail. So, in conclusion, I am not going in details what are different types of conclusions, but in a defined population of severe symptomatic aortic stenosis, patients who were at low surgical risk, TAVR using the SAPIEN 3 system compared to surgery at 2 years demonstrated reduced primary endpoint events, 37% reduction in death, stroke or CV hospitalizations, but more death and stroke events in TAVR patients from 1 to 2 years, and no significant difference at 2 years. Reduced cardiovascular rehospitalization favoring TAVR. And conclusion part 2 was increased valve thrombosis events were found in TAVR groups, especially from 1 to 2 years, and hemodynamic improvements and frequency of moderate to mild paravalvular rigors were unchanged between 1 and 2 years in both TAVR and surgery patients. So, if you see the data, it's very interesting. If you see the US and European data, almost 1,15,000 TAVIs are done annually in Europe, around 60,000 in Northern America. Now, if we gather this low risk group also to the numbers, they expect that its numbers is going to increase to almost 2 lakhs in Europe and almost 1 lakh in US. So that's a huge number of TAVRs in the Western group. So if you see this, if this is a Netherlands trial, if you see this is this column is the surgery and this is the TAVI. So in fact, in 2017 onwards, the TAVR group has increasingly been done. This is a Netherlands registry, so it's an European registry. So their TAVR is very aggressive there, and this is the in general registry in Europe. So coming back to our country now. Now UN says a very important report, which we know that by 2030 will surpass China in population, will become the most populous country in the world, and importantly, Indian population over the age of 80 years also nearly become 10 millions in 2030. That means 5 to 6% of 70 million of Indian population will become more than 65 years of age. That's also more important. Now I want to apply the Western data prevalence of aortic stenosis to our population. Now we find this number that 300,000, the 3 lakh patients will become eligible for TAVR from 2030 onwards. That means we will surpass everyone in cases number in TAVR. But this report, the final line which I have written is from the Journal of Heart Valve Surgery, that India's focus at present is not on TAVR, it's focused on mainly to prevent rheumatic heart disease. So India's focus is likely to continue to address the rheumatic heart disease for now. That's the official report of Indian Heart Valve Journal. So there are a lot of surgeons, they keep us discussing that after some time we will not be having aortic valve replacements. So is TAVR going to overtake SAVR in India? The answer is a big no. At least for next 25-30 years not going to happen because of the two reasons. The rheumatic heart is still also increasing, and it is increasing at a rapid pace. If you see the background, it has crossed already China and other countries like Vietnam and South Asian countries. So valvular heart disease in young also is going to be increasing too much. So despite its enormous potential, TAVR is still beyond the reach of an average Indian citizen. Growth is slow with lot of obstacles on multiple levels, high cost, lack of coverage by a lot of insurance companies. It is ignored by the government policies in most of the cases. Lack of lot of good TAVR operators, lack of sufficient post-TAVR caregivers. Unique anatomical factors for Indian patients like small body surface area, small aortic annulus, small caliber iliac and common femoral arteries, low coronary artery take. These are very specific to Indian population, been already discussed. Indian TAVR industry was also growing very nicely and rapidly with the My Valve from Merrill has really placed a nice place in the Indian TAVR market. Hydra, the other valve, which is from the, I think, Sahajanand Medical, is also on trial. They have started putting in couple of patients in as a trial, but not in routinely in clinical practice. So out of these two valves, the Hydra valve is a self-expanding valve, while the Merrill valve, the My Valve, is a balloon expandable valve. So if you see the implants per year, it's still lacking behind the European numbers. Although this data is slightly older, 2018, we have hardly around, I think, 650 to 700 TAVRs in our country in total. But I think last year we have done, as per the industry, I don't have the concrete data, is around 1500 TAVR that we have done in last year data. Just after COVID, it is almost 1500. Against a surgical AVR of about 28,000 some hundred. So still the gap is still very high in our country. Now the guidelines of 2021, they are very straightforward guidelines. We have all my previous speakers have really elaborately spoken about the heart team. Heart team really exists, and in some hospitals in the terms of some forms where you have to just sign. In some hospitals they really exist in physical form. Our hospital have a real physical heart team where we sit down before every TAVR case. They have to discuss with us. Otherwise, it will not be passed in our Fortis Medical Council. So, if you symptomatic heart team evaluation patients, these are pretty well-defined guidelines. Less than 75 years, low risk for SAVR, STS from score less than 4, or unstable for transfemoral TAVI, go for surgical valve. All other patients, very importantly, can be for both SAVR and TAVR. Definitely patients above the age of 75 years, 80 years, unsuitable for high risk SAVR, STS from or US score of more than 8%, and suitable for transfemoral TAVI, go for TAVR. So I have no problem in our high risk group of patients. I don't want to operate any high risk group of 80 years or 75 years. So gold standard now have been defined that if we have a high risk patient who is extremely prohibitively high Euro score of more than 8% or 10% is extremely frail, TAVR is the gold standard. We should not be doing surgical valve for this patient. This is one of my very favorite slide now. Now intermediate and low risk patients, both these pictures are look same to me. In intermediate group also, I can go for TAVR or SAVR, and the low risk group definitely it almost looks the same. The results will be same like both these girls on both the pictures. The perception different, but you can go and choose both the procedures and pick them up. This is a very important slide again, 2021 EX. So if you see this slide, if you see that favors TAVR, definitely at the age of 85 years, highly prohibitive surgical risk, severely frail, valve morphology is very favorable, femoral access is very favorable, there is mild AR, mild MR, mild MS and TR, 1 or 2 vessel coronary artery disease, left main disease with syntax score less than 22, definitely I will go for TAVR. But on the other side, if it is 65 years, low surgical risk, there is no frailty, valve morphology is unfavorable, femoral access is small, there is concomitant AR, TR and MR, 3 vessel coronary artery disease, definitely it should be for a SAVR. In between, if you see this is an in-between group, definitely the heart team comes when the patient is 75, intermediate risk, moderate frailty, intermediate valve morphology, intermediate femoral access, you need expertise on both sides, and then take a good heart team decision, discuss with the family and go for it. So heart team is definitely important. In our hospital, we have 2 more persons in the heart team apart from the cardiac surgeon and cardiologist. It's a cardiac anesthetist and a cardiac radiologist. So without those 2 persons, our heart team is not complete because the CT scan is definitely, the radiologist is very nicely, they can nicely explain as the CT scan. And the frailty part, definitely we can definitely define the frailty part, but cardiac anesthetists have the parameters to tell us better. And now I am coming to a very small slide that suppose patient walks into your facility and the chamber and say that he is just 55 years, that he has a severe aortic, this 55 is a severe aortic stenosis. So what shall we do? So I think this is the slide I would like to go for. I will go for SAVR first with a biological valve, go a TAVR again after 10 years, again do a TAVR after 10 years. So I can make him sail through till about 85 to 90 years if I go through this approach. Both the other approaches like TAVR first, I think I will be very skeptical. Why I will tell just up to this slide, because it will be extremely difficult to remove the TAVR valve. They are like horrifying valve. You have to be a very good aortic surgeon to take out and explant the TAVR valve. It's a nightmare case. I have seen 3 of them, and I have shown the cardiologist how the valve looks like even after 2 years of implant in any patient. So please try to just aware that these valves cannot be placed in a young patient, because if it goes somehow, it cannot be for a valve procedure at 60 years, it will be nowhere. So this is the picture which I have taken from I'll not say the name of the company, but you can make out by the structure. So these are different, definitely very, very difficult surgeries, and I would not like to do this surgery. It's a real nightmare for us. It takes long time. We have to replace the entire root, and we don't find the coronary arteries even to do a Bental. And then we have to do additional bypasses, put vein grafts into the aorta, they will bleed. So I think there are real challenges. Take home messages, both TAVR and SAVR are there to treat for severe aortic stenosis. SAVR have been there, surgical valve have been there for 6 decades with robust outcome data. TAVR is there, this year it has become 2 decades because it started in 2002. Now we have completed 2 decades. It has also shown very excellent results, and probably will grow further in all these patients in the coming days. Always TAVR when I will go, very high risk surgical cases, with Euro score, very frail cases, and one important case I will say in valve. If my biological valve fails, I will not go. I am not going to operate that patient again when the patient is more than 65 or 70 years. I will go for a valve. And in selected intermediate and low risk cases, definitely if I think that should be go for a TAVR. And always surgical valve. At this stage, all the guidelines say if it is a bicuspid aortic valve, please go for SAVR. If it is a very severely associated with triple vessel disease, definitely for SAVR. Very young patients wanting a tissue valve, should offer him endoscopic or robotic aortic valve replacement rather than going for a TAVR. Any intermediate patient risk who wants to have a durable tissue valve. Thank you for your patience hearing.
Thank you, sir, for a nice presentation. Now the session is open for discussions. Any question? So I'd like to put forward the first question to Dr. Ritwik, sir. What are the long-term results of transcatheter aortic valve replacement? Because SAVR has already been studied for a long time.
Yeah, thank you. That's a very interesting question and very good question. In fact, yeah. Interestingly, to our disappointment, TAVR valves are doing very well. We always thought that TAVR valves will be failing, and but 7-year outcome data have come recently from the SAPIEN group, and they have a structural valvular degeneration almost only about 3.7% at 7 years. So I think that's a very encouraging result for any TAVR valve. However, the age group of those patients, mean age group was 67.5 years. So that's a catch, but definitely in those age group, TAVR really does well.
Yeah, Amit, if I can add here, we have multiple studies. In fact, Notion trial was done with self-expanding valve.
Yeah. So
And the performance of the valve was even better than surgical valves.
Yes.
So the patient processes is matched, the durability. So it is at par, especially self-expanding valve. And with Edwards, we have got some trials, and we have got Yuko-Tavi trial just now published 2 years back.
Yes.
So multiple evidence that the TAVR is lasting more or less, the similar trend is there. We can't say it's still 10 years of TAVR. So 2011, it got the FDA clearance. 2015, it surpassed the surgical counterpart in US and Europe. I don't know what is going to happen in India. But you showed a very good slide. We have a potential kind of 3 lakhs, something like 3 lakhs patients.
Yeah, it is from the Indian
Yeah,
heart valve.
Indian, yeah. So, and I tell you, the number of TAVR operators will be growing exponentially, in next 1 or 2 years. Every month you get a new proctor. I have one case left. I will be proctor for, my valve now. And I see this is an easier intervention than a complex PCI, complex bifurcation, or even a calcified lesion. So it's very easy from cardiologist point of view. Taking from hair to hair, and if the valve morphology is good, it's very easy. And the the price, the cost. Right now, 4 Indian companies, besides these 2, they are in line. Next 6 months they will be launching, or maybe 1 year they will be launching, and the price will be something like CRT, less than 5 lakhs. So maybe.
Yeah, I think that will be a very good thing. Yeah. We need a lot of TAVR valves, because I think as a surgeon, I always feel that there are so many patients that we cannot operate them. Then they are really symptomatic, and they need something rather than a surgical valve replacement. Thank you. I have one question to Dr. Rohit. So you mentioned about dual antiplatelet therapy. How happy you are with clopidogrel as a molecule? Have you got any experience? Because why I'm saying it, I just want to share our experience. Initially, we used to always stop clopidogrel for 7 days before doing surgery. When I was a student and when I was doing the residency, then kept become 5, now 3. Now we don't stop. From our cath lab, Dr. Seth has done she said, Ritwik, just do the surgery immediately. And believe me, the bleeding is almost minuscule. Either the brand which they are taking is not good, or the patient is not responder. Because I can remember those days where a patient is on Plavix, and if I just touch the skin also, they will not stop. Leave aside giving them heparin. And similarly, and I have also seen the same thing slowly is happening and brewing towards Brilinta as well as prasugrel. Now we are very confident. We can operate even next day after stopping. What is your view on that?
One can operate even after 12 hours. That's not a problem with Brilinta.
What is your experience on clopidogrel?
On clopidogrel, I agree with you, sir. That clopidogrel, I feel comfortable to stop for 5 days. If you have to stop for lesser period, even for something
my
like...
question was not that. My question is, after putting 2 drug-eluting stents to LED, are you happy with only aspirin clopidogrel, or you want to add Brilinta? In spite of, in place of clopidogrel?
No, not triple drugs, sir.
Because no, not clopidogrel. Do you want to replace clopidogrel fully with Brilinta?
I think there are a lot of positive things with the clopidogrel. Fine.
We haven't seen much of stent thrombosis.
Okay.
I think clopidogrel have much safety in comparison to the ticagrelor and prasugrel. If you see prasugrel, if a patient is above 60 years of age and underweight, then bleeding is really high. I have seen a lot of cases of the hemorrhage with the prasugrel. And ticagrelor sinus arrest we have seen, and a lot of increase. As far as the Indian context is concerned, clopidogrel I find a better bet.
Okay.
ACS, obviously, ACS.
Yes, you can do.
And regarding your radial artery technique question, we never do radial artery harvest from that arm or hand where we have used for radial artery intervention. So in our hospital, because we use almost 90% radial artery in our CABG cases, radial intervention is not done. Even angiogram also radially not done. And in fact, in some of our cases,
Sir, I come from escorts only. I have worked a lot at escorts, so my culture is escorts culture.
Yeah, yeah. So you must
I'm
be
not a radialist because I because I
You
come
have
from
not seen
escorts.
radial artery. Okay. Yes, sir.
So this was about one slide you had shown. Supposing you have a 55-year-old gentleman walking in your clinic, and what would be the best approach?
Yeah.
So yours was surgical. If it fails, then tower.
Tower. Yes, yes.
So, but with the advent of, as everybody is predicting that more and more tower will be available, it will become logistically more, easier to implant them. So there will be more and more cases which will be coming through the door, which will come for reoperation. So degeneration in these cases of tower. So is it like something similar to the bioprosthesis what you see in the surgical AVR?
So the two cases which I have seen, these are not seen in India. I have seen in Australia only. So in long back, and the new generation valves were coming at that time. So most of them are thrombotic. Most of them have thrombus inside the valve, and then they become dysfunctional. Now coming to your question is very important. I think first of all we should not put a biological valve at 55 years if possible. Because the guidelines say that you should not put a biological valve. But if the patient argues, no, he needs a biological valve, he doesn't want to have anticoagulation, I think SAVR as a first procedure will be better, because with the new Resilia valve technology and all, we have got good outcomes. So we can at least pull that patient about 10 to 12 years, most likely, hopefully, and then definitely we can keep on doing TAVR at least for 2 times. They will do well.
So what happens if it fails a second time?
It will be very difficult then, sir.
So every subsequent valve will be smaller size. Correct?
Yes,
Right.
yes.
Because you are
Secondly,
not expanding.
coronary occlusions rates are very high. Or the valve in the second time. First time is all right. Second time is extremely, because last 2 studies which have been shown, they're extremely skeptical about doing second time valve in our post surgical AVR cases. Yeah, that is a small paper.
I think such concern is very genuine. When I was in Switzerland for TAVI training, there was only those patients who were taken for more than 80 years. Less than 80 years, tower was not allowed. In Netherlands, it's 75 years because the government funds. So government will not fund any 60 years old, 70 years patient. Even if the guidelines says more than 65, we can go. But in India, we have seen in live transmissions, 55-year-old chap been taken for a tower. So it will be his concern is very genuine. What will happen, we don't know.
No, that's going to be a serious problem.
Some regulation will be,
because it's going to be easier for you, but it's going to be more and more difficult for the patient and
Certainly,
for
sir,
us.
certainly.
Because if the patient comes after a couple of failures, then what will happen for the surgeons to do in that case?
Thank you, sir, and it was a nice discussion. Now I hand over the session to Dr. Alok, sir, for further proceedings.
Now I request Dr. Umesh Pandey to give memento to Dr. Ritvik. Now I request Dr. Amish Srivastava to give memento to Dr. Rohit Tiwari, sir. Now I request Professor Sanjay Kumar to give memento to Dr. Sanjay Gupta, sir. पैक करा देना सबको. Now for the next session, I am inviting the chairperson, Dr. Ankit Agrawal, who is a new budding cardiologist, have just joined the Surya Hospital, Varanasi, and Dr. A.K. Tandon, sir, Dr. P.K. Tiwari, sir, please come on the desk, and Dr. Jigyasu Singh, sir. And the first speaker is Dr. Dilip, who is 1 year senior to me in BHU, and he is the celebrity interventional cardiologist of India, and he is one of the most all-rounder cardiologists. He recently did a tower and dual chamber pacemaker and discharged the patient within 17 hours. 24 hours. Within 24 hours. So he have lot of courage, and I think he can do any intervention at any time. As I am his junior, I know.
Thank you, and thanks for the invitation, Alok. It was wonderful discussion, wonderful previous session. So before going ahead, let me disclose that I am a national international proctor for Medtronic, Biotronic, and St. Jude's for CRTs. So CRT indications, tips and tricks, a little bit more technical this would be, but I think it will be worthwhile. So this is basically what a CRT does. You see the ECG left side, LBB, and right you do a CRT and QRS becomes narrow. So the idea of doing a CRT is to bring the synchrony, AV synchrony as well as VV synchrony, and it is not a standalone therapy. It has to come with a proper guideline mediated medical therapy. It is a complementary therapy to medical arm. So one should not think that once we have done a CRT, the patient will not require medical therapy. So the CRT improves hemodynamics, improve quality of life, improve survival, and they cause AV and VV synchrony. And this is what a simple layman analogy would be. When you bring both the horses to take the cart in same direction, you're just going in opposite and failing left heart with a left bundle branch block. The CRT does the heart to move in the same direction, and the cart moves and heart functions. So these are the indications. These are a little busy slide, but I can tell you in a very simple language, any patient in whom you have ruled out any reversible reason of cardiac dysfunction, and his ejection fraction is less than 35%, and patient has a IVCD and LBB with more than 130, non-LBB with more than 150. They all are candidates for a CRT therapy. And when a patient has a high, atrial fibrillation, then again, if the patient has LBB and ejection was less than 35%, you have ruled out reversible ischemia, or even after revascularization, the patient is ejection rate less than 35%, you can go for a CRT. And if patient is on pacemaker, his ejection fraction is still less than 35%, you need to upgrade it. So with these indications, let me go ahead with the CRT tips and tricks, which was the talk. So we look for a proper vein. We look for the left-sided coronary sinus tributaries, which overlaps and overlies the left lateral part of the ventricle. And these are lateral vein, posterolateral vein, sometimes posterior vein, and in extreme situations, a middle cardiac vein as well. So we have some literature published from our center, where we have shown middle cardiac vein and RVOT pacing can also increase the ejection fraction. So to make it more clear how they look like, so this would be a good representation. This is basically a lateral cardiac vein. In RO projection, it looks longer. This is posterolateral vein, which is the target, and then middle cardiac vein, and then over that is a posterior vein. So these three are the targets. And a device is, lead is placed there, and finally device is taken. So to initiate and to start the procedure, first we have to do a puncture, and puncture has to be exothoracic. So if you go inside the first rib margin medially, you are bound to get some chances of having pneumothorax or hemothorax. And if you are dealing with subclavian vein or axillary vein lateral to the first rib, you are safe. And this is a demonstration. This is available on YouTube. And to avoid pneumothorax, sometimes cephalic cut down can also be done. I think this is because of the laptop difference. It is not showing the formatting has gone haywire. So there is also a cephalic approach can be used, where you cut open the cephalic vein and take the things under your guidance. We did it for the first time in country, published it as well, and this is the through cephalic CRT. But the idea of having cephalic CRT looks very nice, but you see the success rate is very less. You can't take 3 leads from your cephalic approach because it's a very tiny cephalic vein. So extrathoracic subclavian puncture is the gold standard, and we should adhere with this. Sometimes there can be problems in venous access. You appreciate this case. I was upgrading this single chamber pacemaker, rather dual chamber pacemaker, to CRT. His ejection fraction 30%. He was constantly going in heart failure, and you can appreciate the left-sided subclavian was occluded. And then I went from right side. You see the right side was such a, again there was a blockage and very steep angle. So it was a very risky case. We had to upgrade it. So I thought, let's do a new CRT from right. There is no way going from left would be right option. And then you see the angulation. It was very difficult to take my wires down after punctures. And you can see the staining here. So till you get staining, you are reassured that the things are not going beyond the lumen or beyond the vessel wall. And till then you can play around. So we went inside and we could finish the procedure. So venous access is very important, which venous access choose. Sometimes in post-CABG cases, this patient has a double valve replacement with a CABG. And this patient had a left subclavian stenosis. And you can appreciate here the dilator. After the 2 leads, the dilator was not going in for the 3rd lead. And then we balloon dilated the subclavian vein, and we could take the 3rd lead down, and finally we published it in JACC. So these are the venous challenges in CRT implantation. You should be ready with all this. So if you don't feel that every case will be a cakewalk in venous access, it looks very simple. Do a puncture, go inside. But every case not simple, especially when you're dealing with a post-surgical cases. They have got very, very diverse problems, fibrosis, and everything. After the puncture comes the coronary sinus cannulation. And sometimes it's really difficult. There can be gross atrial dilatation, there can be anatomical barriers, and these are the tips and tricks. I will show the cases. In a failing heart, there is a steep curve. So it gets further difficult, and there are 2-3 ways to negotiate the coronary sinus. The first is you can take a quadripolar electrodes. These are those who are doing electrophysiology. They have got more command, so they can deflect it and they can go inside, and then you can telescope the catheter over your quadripolar catheter over that. You go in coronary sinus and then give an injection. Most often, what everyone does is we take Amplage guiding diagnostic catheter and search for coronary sinus as we are searching here. You see now we are going in coronary sinus, we inject, confirm it, and then take our Terumo wire down in the coronary sinus and telescope again the catheter up. Many times if the patient has a low ejection fraction, low creatinine, high creatinine, then we directly take our wire up without confirming it with a contrast, and then take your catheter. And then finally, this was a mitral valve replacement case where we did. And you see now, once the catheter is down, the wire is down, then you can take the sheath, negotiate or sheath inside, and then you can perform injections. Injections can be performed either directly through the sheath or you can balloon occlude it. But there is a very important trick here. If you take your balloon up, so Swan-Ganj is not available now in India, I tell you. It's not coming. Nowhere in India Swan-Ganj is available, especially 6 French. 7 French is coming. Medtronic gives, and St. Jude gives a very tough balloon-tipped catheter which can dissect the coronary sinus. So your wire should be up, and this catheter should be up, and you can take the balloon-tipped catheter from these companies inside till the end of the catheter, and then pull the catheter down. Don't push the balloon-tipped catheter up. So this is the way you can avoid dissection, and you can perform majority of the times 90% a simple injection through sheath does the job, and then you do your case. Sometimes you land up with coronary sinus dissection. You see how bad was the angulation, there's a failing heart, and you see I have dissected the coronary sinus. So it should not be a deterrent that you should stop there. As long as there is staining, no problem. Nothing has gone outside the vessel wall, you can still manage, and you can still manage to go inside and do the procedure. You take a hydrophilic wire, cross it, and you see, and you can do the procedure. So CS dissection is not something we should be very afraid of. It can happen, you can deal with this. Sometimes you can encounter very strange structures. So this was a structure which we are encountering every time we are going in. So sinus was here, but this was the structure which is confusing whether sinus or not. And then we did the procedure. Finally, we published it. It was a enlarged singular Thebesian vein, which is in right atrium, which is giving an appearance to a small atretic kind of CS. But we got finally a good CS, and we do the procedure. Now finally comes the lead placement. So how to do a lead placement? Take the catheter till the branch or tributary where you intend to take the lead down. This will give you enough support, and you can place the lead easily. Sometimes you can require a buddy wire, just like coronary intervention. If one wire is not giving you support, you take a second wire, and you can take your lead down. Many times there is a stenosis in the tributaries, and you have to do a balloon angioplasty. You see here, this is a balloon here, and we are dilating because wire was inside, but the lead was not going in. So you have to dilate it with a balloon, just like coronary intervention, and then you can take your lead down. And sometimes you have to use subselect catheters. Inside this sheath, another smaller sheath coming from company. This has got various curves, and then with this subselect catheters, you can negotiate your wire and lead. It will give you more support. So I rate a operator. Stage 1, level 1 is doing a simple cases. Level 2 is taking subselects. Level 3 is diverse anatomy is going from right side, obstruction, balloon angioplasty. So this is how operator evolves in CRT implantation. So you can see here, subselect catheter deep engaged inside the tributary of the CS in posterolateral vein. And then you can take your lead down and giving enough support. So these are some cases, and finally you have to take sometimes JR catheter. You see this JR catheter, and you have to do. So I will show you one very interesting case. You see this one. This was a case where I was going for a CRT, and you see this levophase injection. This is the one tributary. This is one tributary which is favorable. So you can see here I have marked it. So with this impression, I went inside the cath lab and took the patient. And to my horror, this was the venogram. This was LSVC to LA. And then I had to do a CRT. Patient was, he came to me going around multiple hospitals, finally chose me to come to get the CRT done. And this was the CS injection. I had to go from right side and to see how the wire was going up. So there was such a increased flow was there because it was LSVC to LA. The simple injections were not showing up, the tributaries, but we had seen in the levo phase, and we took the JR, and you see how much was the support we needed. This was a GR catheter, and no substrate catheter was sitting here, and this lead has gone inside the tributary, has come inside the coronary sinus. So you can loop it, and sometimes you can make it more exterior. It can come out again from the vein, and then you can make a rail, and you can take your things inside. And then we could do the procedure, and after that it looks so simple. And this gentleman is really, really doing well. He had a very difficult time, now he's doing well. And finally, last two cases, from CRT we have gone another step, that is called optimized CRT. So this was only a 42-year-old male. He was DCM with 28% and multiple hospitalizations, QRS of 180. You see the QRS. So I wanted to give him the best kind of QRS. So what I thought, let me do a optimized CRT. So this was a left bundle lead, and this was the CS lead. and finally we got a QRS, something like this. If we give this ECG to someone without telling him that patient had a pacemaker or CRT, he will pass it as a normal ECG. So this kind of QRS fusion we can get with optimized CRT, and that is another case which we did a couple of days back. You can see DCM, and this was the RBB LAHB. So LBB we get benefit, RBB we don't get benefit, but since he was in low ejection fraction, we had to do something. This was the optimized CRT result. Such a narrowing, and we expect a good result on him. So finally, this is a case where we landed in a dissection and perforation, you see. So perforation didn't deter us to stop the case there. You can appreciate here, you can see the collection of blood inside the pericardium. We did a pericardiocentesis, finished the procedure, it came out. So this is how CRTs can be done. Most of difficult anatomies, provided you are vigilant and lucky sometimes, you have to be lucky sometimes to bail yourself out. Thank you so much for the patient hearing.
Thank you, Dr. Dilip, for such a nice lecture. And the next session is a dyslipidemia guideline update. And we have a very renowned cardiologist of town, Dr. Manoj. Please come and deliver your lecture.
So, for a change of mood from the CRT interventions, now we'll move to the lipid guidelines. We know that it's always prevention which is better than cure, and like many risk factors which we have, like hypertension, diabetes and all, the cholesterol or dyslipidemia is an important risk factor for atherosclerotic cardiovascular disease. In India, the risk factors for atherosclerotic cardiovascular disease, because of genetic reasons also, majority of patients, they have some sort of dyslipidemia. In Indian population, we know that the diabetic population is also very high, and the traditional dyslipidemia which we see in Western population is not here in our population. We have a very normal level of LDLs associated with low HDL and high triglyceride. So we'll be talking about the latest guidelines, American, European and Indian, and we'll summarize also. So the overall approach of all major guidelines, what they stress upon is the assessment of risk, because the baseline risk is the thing which decide the outcome with the available treatment. And all guidelines, they stress upon lifestyle therapies. Most of the guidelines, they emphasize on appropriate intensity statin, and equally important is the monitoring response to all lifestyle and medical therapies. The latest guideline also emphasizes on the role of non-statin therapies in high risk patients. So now coming to the recommendation for measurement of cholesterol. Most guidelines, including the American guidelines, they stress and they say that all adults who are more than 20 years of age and not on lipid lowering therapy, measurement of either a fasting or a non-fasting plasma lipid profile is effective in estimating ASCVD risk and documenting baseline LDL. So it is important not to stress upon the fasting lipid profile. The non-fasting lipid profile is also equally good in assessment of cardiovascular risk. But if someone who is having non-fasting lipid, and if he is having triglyceride, high triglyceride of more than 400, it is advised to go for a repeat lipid profile in fasting state, and this should be performed for assessment of fasting triglyceride level and baseline LDL. So the newer guidelines, they stress that there is no difference in fasting and non-fasting, and equally important is non-HDL cholesterol. And non-HDL cholesterol, this better predicts risk compared to LDL cholesterol. So whenever you advise for a lipid profile, always have a look at non-HDL cholesterol, because now, important is the ASCVD risk assessment, because we are treating the patient, and we know, and all patients, especially those patients who come in the age group of 40 to 70, it's very important to have a ASCVD risk assessment. And for this ASCVD risk assessment, there are many tools available, and in mobile phone, lots of applications, and even in ACC, AHA, this websites, they have many risk estimators, and you just put some numbers, and they will give you your 20 years or 10 years cardiovascular risk. So this is important, and this should be done in all patients, so that you know what their baseline risk is. Now, statin